Today on Primary Care, the primary care physician shortage, hitting underserved communities especially hard.
What drives people out of primary care is the excessive expense burden that people in medical school accumulate.
Hello and welcome to Primary Care. I'm Dr. Lonnie Joe. By the year 2020, the Association of American Medical Colleges predicts a shortage of 46,000 primary care physicians in the United States. Minority and underserved communities will be hit the hardest because they already lack access to primary care physicians. Joining me to discuss this shortage is Dr. William Strampel. Dr. Strampel is the Dean of the College of Osteopathic Medicine at Michigan State University. And for the past 15 years, the college has ranked among the top 10% of all medical schools for its primary care education. Dean Strampel, welcome to the show.
Thank you.
Good. Primary care. Tell us what we should be talking to about, or to the general public, about that phrase. It's thrown around, it's tossed around every day. What does it really mean from an educational and a training standpoint of view?
Well, what we look at, primary care, is anybody that would be the first line of care for anybody. That can be family physicians, that can be pediatric physicians, that can be OBGYN physicians for the women population. And on the federal level, we define that primary care as general internal medicine, okay? And sometimes we include emergency medicine, that 5 group in there. Now, everybody wants to be considered primary care when there's an advantage to it, and they don't want to be primary care when they want to bill for insurance or wherever. So that's the problem we have. Everybody wants to call themselves that, but they don't want to be that. In reality, they don't want to be taking care of everybody that comes through the door.
What effect is the shortage of primary care physicians really having now on communities that need the service the most, and what is the approach as you see it to resolve some of those issues?
Well, I grew up in Michigan, a small town. I grew up in Saugatuck, if everybody knows where that is. When I grew up, there were 2 physicians in town that were the physicians for the entire community and whatever. You go back there now this year, and there's no physicians in that small town. Now, transportation's easy, and they can go 14 miles up the road to Holland, but bottom line is those small communities have basically been, those primary care practices have gone away. And I think it has a combination to do this, that it has become very complicated to run a solo practice or a joint practice, to not have to devote 100 hours a week to see the same patients they used to see in 50 hours a week. It just is that much more complicated, and so people choose lifestyle. They want to go somewhere where they're not the only person that everybody knows and everybody's going to talk to. They want to go somewhere where they know when they're off, they're off. And that's a lure that's happened over the last 20 years across the United States.
Yeah. When is starting time? When is lunch? How many
days off do I get? How many that issue to it? I don't blame them. Everybody wants that. I mean, nobody would want to go to work in a factory that said, well, this week you're starting at 6 o'clock in the morning, next week you're going to start at 5, and we'll tell you when you can go home. Nobody wants to do that. But that's essentially primary care. If you're on your own or with another partner, you're on every day that you're there. And it's very beneficial. But the doctor in my hometown worked 40 years that I know. Bill worked 40 years in that town, and honest to God, in 40 years, never had a vacation. His family did. He never left town. And when he finally died, it was a big loss. But Bill, that was his reward. There are very few people now committing to do that kind of thing. They want a structured lifestyle, and that's the challenge we have in medicine. How do we make that fit? And primary care is very important because we know if I see you early for your blood pressure, rather than wait for you to get symptoms of renal failure or the problem, you wind up in urgent care. It's going to cost you and everybody more money. It's going to shorten your life.
So this whole definition or understanding of primary care has really changed.
Sure.
Simply because it's only fair to expect that people take a lunch or have vacation. But right now, we're having this difficulty helping people, the general population, as well as the people we're training for these roles, to understand that this is what we've been dealing with all along. And in order to actually improve the health outcomes of populations, we need to focus more on this concept, this understanding of what primary care is and how that actually, if nothing else, helps us save dollars in the future.
And we, the medicine profession, we're victims of our own success. Back in the 60s and the 70s, it was a manhood contest in the sense that my chief of medicine, when I was an intern or resident, I remember him telling me, okay, the only problem with being on call every other night was you missed half the cases. And it was not uncommon to work 120 hours, 130 hours a week. And when I was an intern, I had a wife and a couple of kids. I remember them telling me my first day of orientation, kiss your wife now, you'll see her next year. And in my first 3 years of medicine in the hospital, my wife used to bring the kids to the hospital every third night so they could have dinner with me in the cafeteria. Otherwise, I would have never been home to see those kids. And we in medicine started telling people, you need a better lifestyle. You need to change it. So we have work hours now. We have 1 day without patient care. Those are not bad things, but it's changed the profession of medicine over the last 30 years, and it continues to change with that issue.
All racehorses wear out.
Correct.
And that is definitely something to be said for paying attention to the workforce and the needs of the workforce. Let's move from the workforce a little bit to the patient population. We're sitting here in the lovely offices of the Michigan State School of Osteopathic Medicine, right here on the campus of the Detroit Medical Center. What was the thinking in coming to this location for the school and the training of interns and residents?
The thinking was that, and to be absolutely honest about it, I wanted to come to more downtown Detroit area because I wanted to make osteopathic medicine more visible in the minority community. I learned from Lawrence Carter is the dean of the Morehouse Chapel. He and I are friends, and he was up talking to me one time, and Dr. Carver said to me one time, "You cannot be what you don't see." Now that sounds wrong, but it's correct. If you don't see physicians and you don't see people in the community, you don't see osteopathic physicians, we would not get people come applying to Lansing.
And that's particularly true for children. They can't be what they don't see.
Absolutely. And the other issue is, no offense, but in downtown Detroit, East Lansing is like the Wild West. I mean, there's nothing that draws culturally for them. We get lots of people, we try to recruit heavily, but you get a lot of people that go, gee, I'm not sure I want to live in Lansing for the 4 years to do that. Not that we're bad people, but it's different than if you're living in the East Side or Dearborn or anything else. And so I thought having a campus here made sense so people could actually go to college in Detroit, go to medical school in Detroit, do a residency in Detroit, and never have to leave Detroit if that's what they wanted, because I think you got to train people in the places you want them to stay. We take 85% of our students are Michigan residents by our act. We do not seek many out of state.
That's probably the highest of all the traditional schools here in the state.
It's very high in this. I bet you it's 30 points higher than the next closest school. And why we do that, it made no sense to me to bring a young man or woman who may be very bright out of Southern California and bring them to Michigan, okay?
To go back to Southern California.
They might stay here for their training, but they want to be out of here. They're not used to seeing, where's the sun? I have people say that.
You also have the distinction of having more of your trainees stay here than any other medical school in the state.
That's correct. We've been in business since the 60s. We originally started as a private medical school in Pontiac. In fact, I just sold that property that we owned several years ago. That was where the original school started, downtown Pontiac. And we moved to Michigan State in 1969, and we've been there. But about 73% of my alumni that ever graduated from the college still practice in Michigan.
So we're seeing increase in medical schools across the state. You know, we have a new school now at Central, one at Western, the Oakland University School. Will this increase in medical schools increase the number of minority physicians?
I would love to say yes, by the sheer volume of numbers. The problem that we have is that, and that's why we do these high school programs and stuff, we learned that if somebody's really interested in the healthcare field, be that nursing, PA, physician, MD or DO, I don't care. I don't discriminate for that. To get them early, you can't wait until they're a senior in high school or a freshman in college, because they're already behind the 8 ball. They haven't prepared themselves to do that. And the competition, for my school, I get 7,000 applications for 300 spots this year. That's a pretty steep curve. And so you have to make sure you're doing these young men and women, you get them early. So we work with, used to be Crockett High School, but now it's Ben Carson, okay? I know Dr. Carson, okay? Was on the podium when we dedicated the school building. We've done several of the schools around here. We do in Lansing on the east side, we do in Macomb, and we bring these kids and we try to get them interested in their sophomore year in high school, their junior year, so they can make those decisions to make themselves competitive.
Dean, we're going to take a short break. We'll be right back with more from the Dean of the Michigan State School of Osteopathic Medicine, Dean Strampel. More on primary care when we return.
If I got to go to college, oh my goodness. I like discovering new things. You get to see what works for you and what doesn't. That helps you evolve as a person. You get to make like a supernova of skill or talent or whatever it is. I've always wanted to go to college. I just feel like that's my destiny. My name is Queen, and I am your dividend.
Welcome back to Primary Care. We're here again with Dr. William Strampel, who's the Dean of the Michigan State University College of Osteopathic Medicine. Dean, speak to us a little bit about the admissions process. We know that this has been a challenge. The pipeline issues have been there for a very long time. I mean, we have them here at Wayne, we have them in Ann Arbor, where I work on the admissions committee. We've got them all over the country. We look at the AAMC and the issues that they bring about to us. And here we are in 2016, and our numbers are right back where they were at the turn of the century in 1900. Tell us about some of the challenges you're facing in this pipeline situation.
Well, I think if you remember in the 1990s, the AAMC and stuff had that, they used a banner thing. We wanted to have 10% by 20, okay? And I don't think we ever got close to that nationwide on that issue. It still becomes a problem, and I think it's a multi-tiered problem. I think it really is, as the Surgeon General at that time, Dr. Lewis, basically made a comment that the testing that we do, and you got 7,000 people applying for 300 spots, it's impossible to go down and look at everybody and just say, gee, we can always pick the best ones. So you have to have some measure, and that measure was the MCAT, the Medical College Admissions Test. Everybody looks at those numbers. Now, some people use a number here or a number there or whatever, but everybody has a basic minimum number which clears the deck. In that sense, 7,000 applications, anybody that falls in an MCAT below, let's pick a number. The old MCAT score would have been, let's say, 22. We won't look at any application with an MCAT score below 22. Now there's a 3-letter MCAT score. So our number would be now, let's say, 502, 502. Anything below 502, we can't look at that application. Doesn't mean those aren't good people. It just means some reason they didn't do that test. But Sullivan made the comment in his thing that test is skewed toward, I don't want to use the term, but I will, white privilege. White males do better on that test than even white females, and certainly better on that test than black females, black males, and Hispanics. It has nothing to do that they're inherently discriminating against, but they're talking to them in that test about things that may not be in your background or my background if I came from poor America. That in itself disadvantages. So you have to go beyond the MCAT score, which we do, and actually try to interview the people and really look at them and try to find what makes a difference on that issue.
Okay. So I interview students for medical school. I've decided not to look at the test scores.
Okay.
I look at the person first. I try to get an assessment of them instead of having my thought process prejudiced because they've got an MCAT score at a certain level. I think that in itself sort of skews the process. So we're looking at a test that may be skewed toward privileged institutions and people, or the interview process itself, which has lacked a lot. Now, now we're getting into the experimenting game speed interviewing, personal statements that are very questionable about whoever even wrote them to some degree. It seems a hodgepodge. Plus the new MCAT, as you mentioned, which even the prestigious schools don't seem to know how to
Well, this is the
rank
first
it.
year in that
yeah,
three
right.
thing.
So
We're still
so
working.
we're in a state of flux. In the meantime, we have the responsibility of taking care of community, and it stands to reason that we have not done a good job of having the physicians or the providers mirror those communities. So is there a particular effort at the School of Osteopathic Medicine to address these needs? How does the school see this looking 5 years, 10 years from now?
We actively go out into the minority communities, and we actively attempt to get them interested and take a long look. I have what we call young men and women that basically are not quite at that level with the MCAT score. We designed a program where they can spend a year in the getting a Master's of Public Health, and if they do a 3.5 or better in the Master of Public Health, we do 10, 12 a year that we get automatically admitted, okay? As long as they do all the work we want and they get 3.5 or better in that Master's program.
Sort of like a post-bac program?
It's a post-bac program, but they actually get a Master's of Public Health while they're not wasting their time. They get an MPH. And then if they do that 3.5 or better, and we've exclusively steered that program to candidates we think that we want, and I would say we preferentially have put 80% of those students really in the underrepresented minority population that I need. Now, Indians from India, physicians from Pakistan, those aren't underrepresented in the American medical system, okay, to do that. You can look right down here in the Detroit metro area and whatever, you'll see that. So I'm looking at the underrepresented population, American Indians, Hispanics, blacks, okay, Latinos. And I get into the interesting thing because get some people say we take a lot of blacks, but they're taking blacks from Nigeria. Not that I have anything against Nigeria, but we have more Nigerian physicians in the United States right now than they have in Nigeria.
Yeah, that's correct.
And I have a problem with that ethically. And so it's not really taking a black African-American population if you're doing them out of India from bringing them here, or you bring them out of Africa here to do that.
What about faculty and staff in terms of the educational system? How are the numbers looking there?
You mean as far as minorities?
As far as minorities are concerned.
It's always, if you were to say, if you are a black male physician, you are a candidate that I really want. John, Dr. Anderson works with me, and he's very helpful with the community, bringing people in. John Seeley is a black physician that works for me. He's the director of medical education at Wayne County Health Authority, but he's Michigan State employee. I got a young man up here in Troy that I'm looking at, black physician, that I'm probably going to put, if we can close the deal, on the primary care clinic on Mack Avenue. So we're always looking. Do we need more? Yes. But you can't get a physician unless you bring him to medical school.
Absolutely.
You got to get them through medical school before they can teach in medical school.
So it's a pipeline approach, like we look at the ninth grader who can throw a football and shoot a three-pointer.
Well, you pay much more attention to that ninth grader that can shoot three-pointers than they do the kid that's doing well in science.
How about that? Absolutely. Stay with us, Primary Care. We'll return right after this.
There are over 34,000 Daves in Southeast Michigan. Big Daves, medium Daves, baby Daves. At Henry Ford Health System, we're inspired by every Dave out there, and every Shannon, Charisse, Miguel, and Ahmed. Because no matter your name, we believe care should be built around you. Not someone like you or near you, but care designed for just one person, you. Henry Ford Health System, all for you.
Welcome back. We're here with Dr. William Strampel, the Dean of the Michigan State University College of Osteopathic Medicine. Dean, talk a little bit about cultural competency. You know, it's a sexy term that we're throwing around in healthcare now. I think 6 or 7 states have already mandated that part of your relicensure includes a quickie course in cultural competency, as if we can teach something to that degree. What is happening inside the walls of education at Michigan State to address this?
We actually spend a lot of time, and it's a funny thing. In the 1960s and 70s, I trained obviously in Southside Chicago with the medical school. My cultural competency training was on the job on there learning that, because I came from a small farming community and I'm dumped into the middle of, I was 6 blocks away from Elijah Muhammad's headquarters.
Which hospital?
Right down in Ellis Park, 5300 South Ellis was the College of Osteopathic Medicine hospital, right down there by Michael Reese and the University of Chicago. But it was an interesting issue. We talked about it. And I didn't, if you had asked me in the 60s about cultural competency, I wouldn't know. Flash forward to 2000, 2010, I have to train the students to be different about what they do. We have too many populations. In Detroit and in our area, you have many people from the Muslim background that their cultural competency is absolutely different. Doesn't make it wrong, it just is different, regardless of what some of our politicians think. A lot of these people really, they do need health care, and you have to be sensitive to that. We have to know the background in where it's easy to say, gee, I came out of Holland, Michigan. And this is how we did it in Holland, but that's not how they did it on the east side on Mack Avenue in Detroit. That's not their experience. So our physicians and the people we train to deal with them, and the nurses and whatever else, have to know how to deal with those people and the background they're coming from, because it determines how well your information gets to them about, you need to take this medicine for the following reason. All right, good example. I treat your blood pressure, and I know that the side effect of that blood pressure is you're never going to get an erection. That's something that you would want to know in certain cultures immediately, because that's not going to go. To take your nature away, to use a term that now has come there, is a dead start. They won't tell you that. They'll take your prescription and throw it away, and you're not helping. So you have to be able to know what that background is.
The social repercussions behind these things can be very grave. We're living in a community that had a very tragic incident several years ago of a woman of a different ethnicity was treated for a simple urinary tract infection that went through the family, ravaged them because of the social implications that they thought, and ended in murder. So cultural competency is very important. Probably should probably find a different name for it going forward, but it's really an understanding, getting an understanding with the patient that's sitting before you.
Well, absolutely, and you have to, and it's not something you just get. That's why we work at it. We bring people in. We have student discussions. We bring in outside. We did a Pimsleur event, which we actually put students in scenarios with somebody that how it challenges them to not react to that. Absolutely. Because it changes what they take as what their own beliefs are, and realize just because it's your belief, it's not everybody's belief. And you, as a physician, when I read in the paper in Detroit a couple months ago where somebody made a decision about not treating a child because the parents of that child were gay, I go, no physician needs to make that decision. That child is apolitical. That child is who's being treated, not the parent. If you don't believe in that, what the parents do, fine, but you still have to take care of the child. The child is not in this issue. And I thought every physician that went through school needed to know that.
The patients continue to suffer. They are suffering because primary care just cannot catch up with the burden, the disease state burden that we have in several zip codes in a city like Detroit. I mean, we've got zip codes here that are the highest infant mortality rate, highest incidence of breast cancer in females, prostate cancer in males. All of these things are primary care entities, primary care people on the front row, the front line of dealing with these diseases, and we're still pushing. What needs to happen now? Now that we know we have to go in that direction, how do we pick up the pace? How do we talk about getting to the endpoints, the outcomes that we need to achieve?
Fundamentally, we have to change the financial structure for medical education, because what drives people out of primary care is the excessive expense burden that people in medical school accumulate. I mean, rough justice, average physician comes out with $220,000 of debt from medical school to do this. So if I'm going into primary care and I really like taking care of people, if I had a mature family practice in Michigan, I can probably make somewhere between $180,000 and $220,000 depending on the market we're doing in here to do this. But if I go into urology, or if I go into thoracic surgery, or go into there, my income is going to be closer to $500,000 a year. These guys are all, if they're in medical school, they're not stupid. They start looking at it and they go, I have $200,000 debt and I'm making $190,000 a year, it's going to take me X years to even get on top where I can buy a house or a car and whatever. or I'm making $500,000 a year. It's going to pay it off a lot less, and I can do this. So they make a choice, even if they don't want to make a choice, to go that way. I think what we need to do is inverse this. We need to make it profitable, so if somebody wants to go to an underserved area, they get half their debt taken away if they're there 3 years, or you pick a number, I don't care. But then we can give doctors above Clare, in not only inner city Detroit, but you have rural areas of Michigan,
Same problem.
that a woman that has a baby's got to go 200 miles to deliver that baby. Think about it. Now, nature will deliver the baby. They've been doing it before there were you and I in doctors. But realistically, we could provide that if we had the incentives right. And the incentives not be that I think that somebody working in Clare, Michigan, and family medicine probably needs to make more money than somebody in Troy, Michigan, in family medicine. And that won't be happy, but that's really what I think. And maybe not paid directly that way, but maybe they get their debt reduced on their medical education. It would drive more people into primary care, and that's what we need.
Dean, we're out of time. This has been fascinating. We'll do this again. Thank you for joining us. We've been talking with the Dean of the College of Osteopathic Medicine at Michigan State University, Dr. William Strampel. Thank you, Bill. Thanks for joining us. That's all the time we have today. I'm Dr. Lonnie Joe, and we'll see you next time on Primary Care.